Kia ora. Kia ora koutou. Yeah, I'm already getting the signal 10 minutes. Mari ora kia tātou, ka nui te mihi atu kia koutou, e hui mai nei tēnei rā. E tautoko ana ngā mihi mahana, ngā mihi aroha, kia koutou, kia tātou hoki. E tika ana hoki ki te mihi atu kia rātou kua whiturangi tia. Haere atu rā, haere atu rā, haere atu rā, hoki mai anō kia tātou. Ngā maramara o rātou, mā tēnā koutou, tēnā tātou katoa. Kia ora everyone. I'm Tania Hodges and I'm not the bossy one, but I'm just the one that got the privilege of being the MC today. So I want to share a warm welcome to you all on behalf of the organisers, and this being one of 4 of the Matariki Rangahau series. I also want to just do a couple of housekeeping things. So if you haven't already seen, the wharepaku are directly behind us here in the corridor there. If there's an emergency, just get out. There's an exit over there and an exit over there and an exit over there. Make sure you take everyone else and don't worry about your gear, it'll still be there. But there's an assembly point out in the car park just over there. So if there's any need to go out, that's where we'll all meet. Everyone has their lanyards. Is anyone who hasn't got a lanyard? Okay, cool. On the back of it has our program, and we're going to try and stick as close to that time as we can, because we've been blessed with a wonderful big program. If you have any questions, there are people at the registration desk that can answer any questions. And please remember to hand these back when you go, because we're into recycling. Ka pai. There's also at the desk, and just when you come in, there's a QR code. So the team are really keen on getting your feedback on how you found the day. So if you can do that, that would be great. But this is a day for yous. And so we encourage you to feed your soul, feed your puku, as we've had our wonderful morning tea, but to feed your souls, and it's a day for you. And because I know that, many of us, over many years, but particularly if we think about the last 4 years, it's been pretty tough out there. It doesn't matter where you are working, it's been pretty tough. And for those that know me, we encourage you to fill your soul. Because the thing is that many of us give to lots of other people, but we forget to give to ourselves. So we're asking that today you give to you. So, when you think that you have to have your phone on all the time because, the world's not going to survive if you're not there, we ask you that you put your phone on silent, and we also encourage you not to respond to your calls every time it beeps or, every single email that's coming. The world will survive. As much as we don't believe it, the world will survive and carry on. So please use this day for that. We also encourage you to mix and mingle with each other. So I know many of you would have probably come and sitting next to either your whanaunga, your friends, your old mates, your whatever. So we encourage you to mix and mingle. Mix and mingle at morning tea time, at lunchtime. Oh, we've had morning tea, sorry. Maybe we're having another one. Tohu tēnā. But at lunchtime or in the breaks, but mix and mingle with each other, because the key is that really it's relationships and networks that make the difference. And if we have strong networks and relationships, then anything is possible. So I encourage you to mix and mingle. So no room for shyness today, people. So we've had the welcome for you. And the other thing that we normally do too, which is typical of us as Māori, is we do a whakawhanaunga session. But we're going to do this in a super speedy way. So what we're going to do is I want to ask, if you're from this particular area, I want you to stand up. And some of you may stand up several times, that's okay. And so we're going to start down the bottom. We're going to start at Wharekauri, Rekohu, Rakiura, Ngāi Tahu. If any of you are from any of there, we ask you to stand up. Yes, and if you're from there, do a big proud paki paki. Yay! Okay, if you're from the top of the south, Te Tauihu, stand up. Te Tauihu, yeah, Sam, yay! Okay, if you have any whakapapa to Upoko Tika, so the Wellington area coming up the coast, Raukawa, Ngāti Toa. Oh, Sam again. Oh my gosh. Paki. Okay, so if we come up on the other side of the Takitimu Waka, Ngāti Kahungunu, Pahawera, come on. Yes, yay! And then if we come across to the middle, sort of the Manawatu area, then going across to Taranaki, so ngā iwi o Taranaki, Whanganui, that area. And then if we come back up, go back up further on the, going back on the east coast to Tairāwhiti. Yes. Okay, and then come back up along. So we're coming around, so we're going around the corner a bit and we're coming along Whakatō here, Te Whānau Wapa Nui, Mā Tātua Waka. Yes. Okay, what about Te Aroa Waka? Kapai. Tauranga Moana. Joyce. Okay, Tainui Waka. Oh! Tainui Waka in the whare, eh? What about Tūwharetoa? That's part of Te Aroa too, but I'm from Tūwharetoa too, so I've got to make a special mention. Tūwharetoa, yes. Okay, so we're coming back up. Hauraki? Anyone from Hauraki? Yes. Ngā iwi o Tamaki Makaurau? Anyone from that area? And ngā iwi o Te Tai Tokerau? Joyce. Oh, I think there's a bit of a competition there between Te Tai Tokerau and Te Wako Tainui. Okay, fabulous. So so make sure, hopefully you looked at who stood up and you might make a rekindle or reconnection with a whānau member. So encourage you to mix and mingle. Okay, so without further ado, I'm going to welcome my whanaunga. Now I've got to get the sheet. Now up there, oh, can we flip the bio up there? All this fabulous technology here. Is there a bio up there? Okay. Okay. So so my whanaunga, Lady Tūreiti Moxon, so ask Tūreiti if she can come up. Ngāti Kahungunu, Ngāti Pahowera, I should say Ngāti Pahowera first actually. Ngāti Pahowera, Ngāti Kahungunu, Tainui, Ngāi Tahu. So if so Tūreiti is, Tūreiti is the CEO of Te Pōhau Health, so this is part of this beautiful venue that we're a part of, and she's also my whanaunga. Actually, there's lots of people here in my whanaunga, and I often say to Tūreiti, because she's been involved in many things, you know, that I usually have to see her on TV rather than see her in person, because she's fabulous and done many things. So if you get a chance, have a read of her bio.
Kia ora koutou katoa kanu te mihi atu kia koutou I tēnei wā. I runga, I raro I ngā kaupapa nui. I runga I ngā kaupapa nui, I Wainganui a mātou, I raro I te maru o te hauora, I tēnei wā. Nō reira, kia kaha, kia maia, kia manawa nui, kia tātou katoa, I tēnei wā. I tēnei wāhanga o tēnei wā, mo tēnei motu. Nō reira, tēnā koutou katoa. Kia ora, everybody. It's lovely to be here today. And, I understand only too well some of the awanga that's going on amongst many of you in terms of the changes and the referendums that have been coming thick and fast all over the place. So my heart goes to you. And what are we very good at? We're very good at being resilient, and we're very good at standing our ground of what we believe. So kia kaha tātai. So kia ora koutou katoa. Now I just want to have a little chat to you today about what we're doing at Tākiri 2. Now Tākiri 2 is our new facility in Enderley. If any of you have a chance to go drive by, you're most welcome to do that, or even to call in. But Tākiri 2 was open this year, and I just thought I'd share a little bit about what our moimoia is around Tākiri 2, because that name was given to us by Kingi Tuheitia, And that was the name they gave to their hui for kotahitanga. When he called all the people together to stand strong and stand as one. And that's what they did, exactly what they did. So, now that's not the right one. No. Okay then. Right. Well, you're not Millbrook, are you? But anyway, here we go. So that's what you get for cut and paste. Aroha mai. Right. So I'm going to talk a little bit about these things today. I'm going to talk about Tākiri 2 and our vision behind Tākiri 2. I'm going to talk about our partnership with RHCNZ, which is a radiology JV that we have connected up so that we can get into diagnosing early. We have a GP clinic in that whare, and we also have and will have, if only they'd get cracking and come. So I'm putting this out to all of you over there at Whatu Ora, to get those specialist clinics moving. So, and then I want to talk a little bit about our art studio. So this is our vision. Kia whakatinanatia ko te ihi ko te wehi, te mana te tino rangatiratanga o ngā me te oranga o ngā whānau. Now, we changed it. That's why I keep saying core. But anyway, the vision behind that has always been whānau at the heart of everything we do. And I think if only health could get back to whānau being at the heart of what we do, instead of clinicians being at the heart of what everyone does, or surgeons being at the heart of everybody of what everybody does, I think we will change the world. But unfortunately, that's not a thing, is it? Oh, now I usually finish with this whakatauki. I usually finish with her because, you know, for many of you who know who Te Puia was, Princess Te Puia, her vision was to have a hospital here, and she wanted and she dedicated Mahinarangi at Tūrangawaewae to be that hospital. And at the last minute, the 11th hour, it was chopped. So, you know, the government giveth and the government taketh away. But anyway, now, because we had a dream, and that's why we put that there, because we had a dream, and that dream will come to fruition and is coming to fruition now. So that's what it looked like last year, actually. And that was our concept design. And we are right in the midst of the people of Enderley. Now, they were going to, Kāinga Ora, we're going to change that all up. And they were going to actually put a whole lot of new housing in there. But that's all changed too. So we shall see what happens in that space. Those are the 5 biggest killers of us. And as much as we want to, you know, change that around, it's not going to change anytime soon. And so I'm going to talk about some of those statistics that surround these. And that is why Tākiri 2 came into being, to focus and support our people through their health needs so that they get in front of the doctor before they end up on the slab at the hospital in A&E. Right, so there you go. So we've got the wide range of social inequities, nothing new to all of us in the room, but they are related directly with colonisation. And a lot of people say, well, colonisation happened many years ago. Well, it's happening again and again and again, and it's still happening today. In fact, it's blatantly happening today. And as much as lots of people want to do lots of things about it, it seems to continue. So, so basically, what the Waitangi Tribunal has said around this is that its impacts are ongoing, never changes, and it will continue to manifest as institutional racism or inaction in the face of need. So on average, we have the poorest health status of any group in Aotearoa. We're twice as likely to die of preventable diseases, twice as likely to be discriminated against in health, and Māori are less likely to be referred for diagnostic tests. So this is our reason why we have done what we have done. So again, the statistics are stark. And, you know, as much as this government or previous governments or whatever can say, we want to change this. We want everybody to get the same. We want the whole world to be a different place. Well, they can say all all that they like, but unfortunately, nothing has changed. So our job, your job, together our job, is to change it. And the only way we can do that is to realise our own tino rangatiratanga and make it happen in a way that we are not beholden to others telling us what to do, how to do it, and when to jump. And that's unfortunately the climate that we have been living in, the environment we've been living in for too long. So there the statistics are stark, yes. We still die twice, 2.5 times higher of cardiovascular disease, stroke mortality twice as high, heart failure 3 times as high, all types of cancers twice as high, and lung cancer probably the highest of them all. Lung cancer, actually, I think it's closer to 5 times higher, and for our men, 3 times higher. So this hasn't gone away, and will it go away tomorrow? I don't think so. So I want to introduce you to Tākiri 2. So Tākiri 2 is has a number of parts to it, and I'll take you through what those parts are. But the most important thing for us is that we have a joint venture with Pacific Radiology, who are a part of a much bigger group of people, of cardiologists, apparently the biggest in the country, and they do about 60% of hospital radiology. 60%. Guess how many Māori there are radiologists in our country? Anybody want to guess? No, oh, yeah, we've got a couple, but thank you. Yeah, no, we've got 3. And ask me how many Pacific Radiology, how many Māori staff they have in theirs. None. And in fact, there are very few Māori in this space at all. So that is another one of our visions, our dreams, to make sure that we train up our people, pathway them in to being radiologists, but also being technicians, getting them on that path. So that's Tākiri 2. So we have directors. Our directors were appointed in March, and our building was opened in April, and we have we're working on our constitution and joint venture agreement. So that's what we're going to be providing, their imaging and all those services, as I've already mentioned at the beginning. They will all be operating from there. Some of them are already operating now. But this is Pacific Radiology's values. They almost align with ours, but patients, ours is whānau, and it doesn't matter who they are, but pretty close in terms of who they represent. Now, those are our machines, and they're all brand new machines, and they're all in there now. And those are the kinds of things that I want to see our young people have a vision of, that they can do this, because actually, to be honest, we've been shut out of that space for a very long, forever, except for these 3, and they're like hen teeth because I haven't met them yet. And I was down there for that conference down in Queenstown, and I didn't meet one there either. So there you go. So so those we also have a partnership with Whatu Ora, and those are the list of services that they are going to bring in to making access a lot easier on our whānau and for our whānau. Those are the services that we've got. We're still working on the mammogram. That's so that it can be joined up with the Waikato DHB, so we can get a lot of those people who actually aren't seen, don't want to be seen there, but will come to us. So we are really, really focused on our own people and our own whānau, but we're also very focused on our children, on our tamariki pepe. And before Whatu Ora, Te Aka Whai Ora was disestablished, we won a contract called a Kahu Taurima, and that's to follow children through from 0 to 5 years of age. But these ones here will give our babies the opportunities to be seen a lot quicker, to be assessed a lot quicker, and to be dealt with a lot quicker, given the kinds of supports they need early, rather than waiting until they're 7, 8, 9, 10. You're a bit over the, bit past it by then, but to get in early. And that's the reason why we have really focused hard on those things. But you can see that cancers are a part of that. Cardiovascular is something we still need to land, and I can see Julia over there, my friend, probably my one and only friend. But anyway, from Whatu Ora, yes, there's plenty. But anyway, she's been one that's been part of our governance of this whole thing, and very, very supportive. So kia ora koe to you, Julia. Right. So that's our GP clinic there. And basically we'll have 2 doctors sited out of there, 2 Māori ones. Ooh, do you know how hard they are to land? But anyway, they're in there. Now this is our other part where we've got some training rooms and whatnot. But the beauty about our building, and when you start thinking about buildings, when you go into them, always do it in a way that you can change it up. That it's not, you're not stuck and think that, oh, it's going to be for this, and then something changes and then you want to change it to something else. You can. And that's how we've done these our buildings, so that at any point in time we can move things around and bring people in that perhaps need a bit more space or smaller space or whatever. So, and this is Te Tau Ihu, which is our mahi toi. And these young people here have found who they are through just doing what we know to be the most healing of all things, doing carving. And those young fellas there, some of them were not engaging. They weren't engaged. Some of them didn't even speak. Some of them they all thought was on the spectrum, and basically didn't know what to do with them. These kids were in the hard basket, too hard basket. And look at them, beautiful. And they carve those miri. They carve those miri, and then they give it to their significant other. And I tell you, ka tangi, ka tangi, ka tangi. They cry every single time because they can't help the wairua that's in them, the wairua that comes from the taonga they have created with their stories on it. And when they hand it over and give it to the people that they love most, and sometimes don't always love them back, I tell you, it's the most healing, cathartic thing you can ever hope. And now we have 6 schools, 6 primary schools that our carvers are going into to do the same thing. And these children are now thriving at school, thriving. So, I think that we, kei a tātou anō te aratika, we have the answers. We have the answers. And we don't need to be told by someone else that they know what's best for us. So I wanted to finish with this, and I think I've had plenty of time. And I didn't get the 5 minutes, so I must be all right. I must be way in time. So so this is of course from Potato to Whetowhetho, and this is what Te Kōhao is really founded on. And this this whakatauki is what those pillars that you can see there, those po in the front and in the back stand for, the three middle. And while we are not tainui in terms of who we are iwi-wise, that we are mātā waka, we have a very strong link with the mana whenua here. And so it is really important that that whakatauki, which was bestowed upon, our name, Te Kōhao, was bestowed upon us by Te Ariki Nui, Te Ati Rangi Kahu. So I leave you with that. So nō reira, ngā raurangatira mā, tēnā koutou, tēnā tātou katoa. Questions? What time? Huh? Yeah,
Say something
ask
else.
questions.
Yep.
Did I want to?
Maybe two. Whetua.
Oh, okay. Okay, anybody want to ask questions? I've got two, and you might be the lucky one. No? Ka pai? Oh, kia kaha koutou.
So let's do a big paki for Tūreiti. So for me, there were some real key messages in there for all of us to reflect on, particularly how we are, whether in service provision and rangahau, whatever area we are, but the reminder for all of us that whānau are at the heart. And so it's not about, you know, government order or provider order or consultant order. It's about whānau order and whānau truly being at the heart. And I want to acknowledge Lady Tūreiti. I should be formal, because she's even though she's my whanaunga, I go Tūreiti, but Lady Tūreiti, for the vision that they had around Tākiri too, but also there's been years of work behind. There's a whole lot of other things. She could have spoken for the whole day on a lot of the work that's been done from Te Kōhao Health, starting off at Kirikiriroa Marae, and then the huge facilities that they have there, and Enderley and other places that they've been to. And I just want to acknowledge you and the team for the healing that you do with whānau. And you gave some examples there, you know, the healing a tinana, a wairua, you know, a ngākau, Māori really for our whānau. So here's a token of he tohu aroha tēnei kia koe. Okay. And Tūreiti's just asked me to also acknowledge Denise Kingi, who's sitting there. Denise, can you just sort of just put your hand up or stand up? Oh no, not a finger. Put stand up. Just quickly stand up. I said so Denise is on the board. She's on the board of Te Kōhao Health, but she's also one of the first members, staff members of Te Kōhao Health many years ago. Oh no, it wasn't that many. Only a couple, Leighton. only a couple. So another. She's my tuakana too. So another, you know, that whakawhanaunga stuff. We've got to make it tight. So whanaunga here and whanaunga there. So another big paki for Tūreiti. So, at this time, we're going to move on to our next presentation. So can I ask Karen, Norman and Lizzie to come up? And while they're coming up, haven't we been blessed by having this wonderful whānau reunion with all of us coming together? So I asked Karen, are we able to put up their profiles on the bios up, please? So rather than me read out the bios, you'll have them up on the screen. But one of the things I asked both of them what they're passionate about, and Karen said she was passionate about the care of older people and how we make the best life for them. And I asked Lizzie what she was passionate about, and she's passionate about palliation, oncology, and supporting whānau. So with that, let's do a big paki for them.
Everybody. Ko Karen Norman talking where I'm currently a principal advisor with the Department of Corrections, and we're here today to share a journey that we have started. We haven't finished it. It's a long, hard walk, but it's to support people that are in our care in their last journey on this earth.
A tēnā tātou katoa, ko Lizzie Kepa Henry tōku ingoa. I work for Corrections along one of my most favourite people, Karen. I'm the Māori Nursing Health Services National Lead. I also want to acknowledge Grant, who's sitting out there over there. He might come up and join us at some point. But anyway, nō reira tēnā tātou katoa. Koe.
So I want to start off just by sharing a little bit of information about our community. And our community is very unique in New Zealand. So we have approximately 9,700 people actually in our care in prisons across New Zealand. And I say approximately because those numbers change daily. In fact, they change frequently every day. But there is approximately 53% Māori, 12% Pacifica, 35% non-Māori, non-Pacifica, and that includes Asian, Middle East, and that sort of those sorts of ethnicities. And about 12% of our population are over the age of 55. And that's a significant number in the environment that we are caring for them. It is estimated that greater than 90% of the people in our care have previous or current mental health or addictions diagnosis, and they live across New Zealand in 18 prisons.
You can probably imagine too that if they didn't have one of those conditions, in particular mental health, you can guarantee that they will leave with that.
So these are the sites of the prisons across New Zealand. Of the 18, 17 of them are run by the Department of Corrections, and one of them is a private-public partnership with Serco. So a few years ago, the Arapatama Aotearoa developed the Hokai Rangai strategy. And this is to deliver outcomes with and for Māori in our care and their whānau. The aim is to address the overrepresentation of Māori in our care and to try and bring that back to one that matches the general population. The key principles are partnership and leadership, humanising and healing, whānau, Te Ao Māori worldview, whakapapa, foundations for participation. It's also really important that we maintain our staff wellbeing and safety in amongst the work that we do with the people in our care. So just some of the things that we have to work within that make the work that we do different and unique. So under the Corrections Act, we have a area called equivalency of care. And it says that prisoners are entitled to receive treatment that is reasonably necessary. So that is the acute care that we give, the emergency care. We are there to support them no matter what time of day or night it is. And we are there to initiate and facilitate the healthcare that they need. All prisons must have a health centre that is adequately equipped for the health needs of the prisoners. And we have health centres, obviously in all of our prisons, but for a lot of them we have separate wings or separate blocks that themselves are within a fenced environment. So we have a lot of small clinics dotted around many of our sites. The equipment and facilities must be such that the department is able to provide healthcare to a standard that is reasonably equivalent to the standard of healthcare available to the public. Now, I would really love to have all that lovely radiology equipment that you've just got. We don't. We do have dental clinics on our sites, and we have obviously health clinics and the ability to provide urgent care. The health services that our teams provide, primary health and acute care. And we often refer to the care that we provide as primary health plus. So we do provide primary health, but we provide a lot of ongoing education, support, vaccinations, those sorts of things, because a lot of the people in our care have not engaged with healthcare prior to coming into prison. Obviously, mental health is a huge part of what we offer and what we do with the people in our care. Addictions, disability health, psychology and programs, so programs to support people to address some of the issues that they've had and some of the problems that they've had in life that have brought them into our care. We have Rongoa Māori practitioners and Mātauranga Māori, and we have multidisciplinary teams. So we work, our mental health colleagues, our psychology colleagues and our health colleagues work together to support the people with the care they need.
Just in terms of the Rongoa Māori, within corrections, we have a team called the Toiora team. And so we are currently working through with Rongoa practitioners around the country to look at how that service can be implemented and partnershiped with Whānau Hapuiwi.
So holistic wellbeing is really important to us, and overall we use the Te Whare Tapawhā model to support the people in our care and to support the services that we develop. It's an ongoing journey for all of us every day, and we try to always put the people in our care at the heart of what we do and think about what it means for them and for their whānau and for their wider community. And we always have an aim that one day those people are going to go back to their community, knowing that there is a small number that are not. So in 2023, Arapatāma Aotearoa released the Ageing Well Action Plan. It had 6 strategic focus areas, which are national leadership, ageing well, acute and restorative care, living well with long-term conditions, supporting people with high and complex needs, and a respectful end-of-life care. And I was the lucky person that gets to lead the implementation of this action plan. So this talk now is really focusing on that respectful end-of-life care. And this came about because we have people in our care that are older, that are in our care for their lifetime, that have been with us for a long, long time. And often these people they become disengaged with their whānau, they become disengaged with their communities. They see their home, their community, their whānau as the people they spend every day with. But in amongst all that, we realise that with this older population that we've got and with these people that have been with us for a long time, that there are going to be an increase in number. It is a small number, but it is an increase in number that are going to end their journey within our care. And we need to actually address that and provide for those people.
And so part of that, from a Te Ao Māori point of view, is as you saw the figures at the beginning of the presentation, with over half of the population being Māori, what does that look like for our kaumātua as some of them, as you heard, won't ever come back out into the community, but for the ones that might, how was it that we transition them into the community and look after them? Because if you think about the gap, some of them there, for 10 years, someone for 2. If you think about that gap in terms of the environmental change that they're going to come into, you know, some of them are still working off those push button phones, you know, those little things, and yet we've got now a different technology and they are not up to date with that. They don't have, I think it's really important to understand that they don't have the same access to what community primary health has. And you can't treat it the same either because it's very different. And so we need to look at what are the cultural safety aspects of that as they transition, or if they don't transition, what that might look like. How do we address the cultural appropriateness of bringing them back out into the community and understanding their needs? And how do we also support their Māori self-determination, their mana motuaki, because that again is different. But always remembering, and I know I do want to acknowledge, because I just feel a little bit of a heartstring pull here. My sister's sitting at the back there with some of my children. And right now we've got a young 25-year-old sitting in this very position. And so when we talk about whānau hapuiwi, that is great. And we need that. But what we need to be focused on is actually person-centred. And only upon the person-centred request should we be involving whānau hapuiwi, because it's very personal. And it's really hard to understand what that might look like from where we're sitting. But when you're that person in that seat, it's about their wishes. And so how does that look and how does that translate when we've got people in our care who have disconnected from their whānau? Not because they wanted to, but sometimes the behaviour has caused that to happen. And so, as Karen mentioned, their only whānau sometimes are the custodial officers or the nurse or the case managers. And so how do we support them in terms of their vision and their understanding of what whānau is? Sorry, can you?
So just a little bit about some of the issues that we're battling with in terms of the process of people ending their journey with us. When someone dies in our care, whether they're inside a prison facility, they're in a hospice, they're in a hospital, but they're still under our care, it's considered a death in custody. And what that means is that there's a lot of legal requirements that go with that. So it's not a smooth journey. It's not the same as someone that's dying in their own home, choosing to die at home with their whānau around them and the process being smooth and planned and talked about. It is, you know, there's a lot of reports and investigations that go with that, even if it is an expected death. Prison sites do not have capacity to provide overnight care. We do not provide a hospital wing. We don't have 24-hour nursing services, except one site. We have one site in Wellington, in the Wellington area, that has a high dependency unit for our high needs clients, whether they're disabled, whether they're old, but they have high needs, high support needs with personal cares, with the ability to just continue day-to-day living. It's 20 beds. And they don't have overnight nurses, but they have overnight healthcare assistants. But that's 20 beds to service our population of over 9,700 prisoners. Obviously, not all of them are old or disabled. We have limited capacity to support with personal cares and high need nursing cares. We again don't have the ability to just employ staff to do that. And often people that have these high needs are dependent on their cellmates if they're sharing a cell. other prisoners that are in there that they have made relationships, friendships, whānau type relationships with. And also our custodial officers are often helping these prisoners with the basics of getting out of bed, getting themselves to the dining room for meals, those sorts of things. So when someone is at the end of their life and facing, that last journey, they may want a compassionate release. They may want to be released into the care of their whānau, into hospice care. So we look at the compassionate release process. Again, it is very much driven by the person themselves. We can't apply for it and tell them they have to go. It has to be something that they want to do. And it's about an early release from the custodial setting. And it's usually for end of life or significant health reasons. It can be arranged within a very short time frame, but there are still legal requirements that have to be met. The decisions for compassionate release sit with the parole board. So it's not a decision that's made on site with the people that have been caring for that person. And the risk to the wider community is always a major concern for the parole board. And as people that care, we often weigh up, what their care needs, what their personal needs are, before we weigh up the reasons that they are in our care in the first place. The parole board looks at it from the other side. They look at the reasons they're in our care in the first place and then look at their personal needs. And there has to be a safe release plan, and that's safe for the person, it's safe for their whānau, their community, and the people around them. And there has to be appropriate supports in place.
We're on a time frame here. Can you skip to the next one, please? Because I'll try and encompass it all in that one. No, the next one.
Next one.
So at the moment, Karen and I are desperately working with many of the agencies out in the community, trying to get links in to see how we can best support people in our care. So we're currently working with one of the local hospices in Wellington, who is connecting us with Hospice New Zealand. And it's really around when people are released under compassionate release, how do we support them in their whare with their whānau? Apart from the Māori and iwi service providers, but we will always take any offers to support whānau. But at the end of the day, like I said, it's about the individual person and their wishes first. So we are looking at what advanced care planning might be and how we might support whānau to have their wishes heard. But sorry, Tanya, I know that we are on a short limit, but I really want to, can we push the YouTube clipping? And the reason why I wanted to play this, I don't know, do any of you know who Kirikara is? Kirikara? No Ngāti Porou? She was a well-known Māori kuia that went to Oregon to do her training as a teacher. But this video was made and she wants it shared with everyone. And so I'm a advanced care trainer, national trainer, and so I really wanted you guys to see this because I think it's really important in terms of how we work with our people, not just inside the prisons, but actually in the community. Can you push play?
Going to work.
Is it going to work? While they're sorting that out, are there any questions? Kia ora. Yeah.
Yeah.
Yes.
So all of the presentations will be archived and made available for you. Yeah.
I think the other thing that we've tried to bring into what we do is we've rather than trying to develop our own care plans, we've adopted the Te Ara Whakapiri guidelines for guidance for the last days of life and adapted them to our setting to try and put round a framework for the people in our care so that we can provide them and we know what to ask for when we need to ask for care and support with that. And I'm not sure the video is going to work.
You just type it into the YouTube, Kenny. Thanks. Any more questions while we're waiting? Kia ora.
Can't answer that with absolute numbers because it's not something that we actually collect data on at this stage. It's not a lot of people that are going through this process anyway. We do try and work with them obviously before they get to the end of their life. Once they've had that diagnosis of a terminal illness or they've got an illness that is bringing them to the end of their life very soon, we will try and work with them. But sometimes that process, because as I said, they have to have a safe environment to go through. If they've been estranged from their family or their community, we have to find a home for them. And that's not always easy. We try and access aged care beds when it's appropriate and when we can, or palliative care beds when we can. But as we know from the community, there's not a lot of those. It's a hard ask to get anyone into those beds. The parole board won't make a decision on whether they will release someone until we have determined where they're going. So we can't even start the process until we've identified a home for them.
I think too, there's end of life, there's people who are heading towards end of life, but there's the other one, which I really want to encourage you all, and that's the assisted dying process. That it's really important that you have some feed into that and shape that act so it suits our people. But for people in our care, the difficulty we have is that it cannot be brought up if they want to access that service, and it cannot be brought up from a health practitioner, whether you're a doctor or a nurse. So if they want that conversation, there's an actual process. And I think it's the same as how that occurs in the community. Oh, here we go. Great.
Ko hekurangi te maunga, ko waiapu te awa, ko Ngāti Porou te iwi. Tēnā koutou katoa. When people die, a lot of them are frightened, as I am, because you don't know where you're going. All you know is this mythical place called Hawaii. I moved to Te Puia Hospital because my family had been here, had been well treated. Oh, kei te a koe.
Hi.
I get visits from lots of people. This is a lovely spot to be. Since I got sick, I started fretting for home. Rakitukia is a little place by a river. It had wonderful views of Mountain Hikurangi. We had 13 children in the family, and we all grew up speaking Māori. And if you wanted to go anywhere, there was no car, no bicycle. You caught a horse. We realized that going to boarding school was an escape, and those were our learning centers of Pākehā learning. And it was hard going, but we survived. And I won an AFS scholarship, which took me to high school in Oregon. That's where I got a feeling about it being worthwhile, fighting for things that keep people upright.
Kiri lived most of her life in Wellington, initially as a teacher, but then as a lecturer at Teachers College. And she was involved in the arts and drama, in writing and in film. So she was definitely high profile and seen as a very progressive woman and very important in terms of the Māori scene in Wellington. Once she left to go teaching, she didn't return to Rangitukia until she retired in her late 50s.
I knew I wasn't very well, And I thought it was cancer because I was busy diagnosing myself, as a lot of our people do. They said to me, hey, how to go get the takuta, go to the doctor. They don't tell me directly what disease I had or they thought I had. They told a little group of the family, but I was brushed off when they had a hui without me.
Living in Rangichukia, because of a number of health issues, became unworkable. And she was moved into the hospice here at Te Puia Springs for what we were told was palliative care.
Being home and being cared for by home people. I never thought it would be important, but it is. I'm worried about who's going to look after the mokupunas and what will the world be like for them. Being remembered and hoping what you stood for was going to give the next generation a focus so they keep, the circle going. Don't cry for me, get focused on the future. Everybody has to go sometime. It's something that I think every Māori faces up to. And all you have to make sure is that your canoe is ready and that you've got your paddle on board, because you've got to have an ending to the story.
I just want to acknowledge Kiri. She passed away in 2019. Kia ora.
So
You can sell this
just go back
$5
to the
spatula on
slide.
Amazon and can.
So I just want to wrap up with two of the final things that we are starting to look at. And the first one is the program No One Dies Alone. And I first became aware of this when I worked in Rotorua. And we've talked to the people that started that program in Rotorua, and we've also talked to Te Whatuora nationally, who are looking at supporting that program through the hospitals around New Zealand. Unfortunately, they're only looking at it within the context of a hospital setting. So we have investigated what it means and what it might look like if we have that program running within corrections, and how we can facilitate that using our staff and our and the people in our care as the volunteers that support people that are dying alone. So yeah, it's about making sure people don't feel isolated. And as Lizzie alluded to, assisted dying, we have currently had 2 people have initiated this journey whilst they have been in the care of corrections. They haven't completed that journey with us. Both of them ended up in hospital and passing away before they could actually complete that journey, but they did ask the questions. It has raised a number of questions around how we operate and how we can better support these people. There are a number of barriers to people in our care. They don't have access to the internet. They don't have access to social media. They don't have access to phones. When they do get a phone call, it's to a listed number in a public area. So it's very hard. But it's a journey that we're going to develop, and we're going to work with the people in our care to support that, so that it is a choice that they have should they want it. And that's us.
Just a big acknowledgement to Karen and Lizzie for the work that they do. And it doesn't matter where our whānau are, we need people who are compassionate and who care. So I just want to just an acknowledgement to you, Karen. And one of the things I was thinking about when they first started off, I thought, why do we need so many prisons? Not that this is a political statement, but it is a political statement. We don't need more prisons to lock up more of our people. Yeah. But yeah, a big acknowledgement to both of them though. You know, the end of life is really important. I learned some things there. Did anyone else learn some things that they had in there and some of the statistics? But I also loved even though it took a couple of minutes to get going, I absolutely loved the what do you call it? The YouTube video that we had there of Kerry Carr. So just a big acknowledgement to her and to her whānau and the things that she contributed to. So our next speaker is Dr. Maida Luka. Where are you? Oh, there you are. Choice. So while she's coming up on stage, I just want you to take 30 seconds to share with someone next door to you. You've only got 30 seconds. I'm pretty strict on this. One of the things when you come to any wānau or any hui is that we can fill ourselves with knowledge, but the key is actually what's the action, what results from what you've learnt. So you've had a couple of wonderful speakers, 3 wonderful speakers have already spoken. I want you to think of one thing that you've heard of that you think you can do something about or something that you can implement in your mahi. 30 seconds from now, Myra comes up. Right now, I haven't got the bios.
That's okay. I'll get them to introduce
You
themselves.
guys can introduce
Yeah.
yourself. Say, yeah. Okay. And you turn, okay, your 30 seconds is up. So please be silent. The last person who doesn't stop talking is going to do a waiata. So please be silent. So I'd just like to, if everyone can put their hands together for Dr. Maida Ruka and her team.
Morena koutou. It's so beautiful to be here today and as it was said earlier, to reconnect with whānau that we've traversed along many journeys in health and hauora over the years, and just to see how everyone is on the pathway at the moment. So it's been really beautiful to share a cup of tea and share time with you this morning. Ko te mihi tuatahi ki te atua, te mihi tuarua ki tēnei whare a tāhua kia whakamahana te kaupapa o te rānei. Ki te kai karakia o te ata, tēnā koe, me te kai kōrero hoki. Kia tau te rangi Māori e ka tū te aroha ki ro te ruma. I just want to we will be talking today about our hospital service, the whiri model of care, but whiri is quite a big kaupapa, and you'll be hearing a bit more from our other whiri team members in research later on today. So to kickstart our presentation, I just want to introduce the rest of our team. Okutuahine here, just come forward and introduce yourselves.
Kia ora koutou, ko Rhiannon Takuingwa. I'm Rhiannon, I'm one of the Whirihohi Pera nurses.
Nā tēnā tātou, ko Mr. Tāpara, te punia tōku ingoa, ko ai te kai whiriwhiri.
Kia ora. So, whiri, as I said, we are a hospital service, a kaupapa Māori hospital service at Waikato Hospital. The hospital service was born out of a need to really try and use whatever influence we have, both within the health sector, but also in the community, to embed some changes within the hospital services that we've seen across planned care. So any booked appointments, but also we were also looking in ED initially, and to try and optimise the pathway for whānau coming in with their tamariki, and sitting in ED and what their pathway looked like on the way up to the ward. So that's where FIDI was initially, the genesis of FIDI was through a piece of work called Hearty, which looked at co-designing with whānau a wraparound service to meet the needs of whānau that were coming through ED, going to the ward and potentially coming back through ED within days. So the service initially, what it looked like was a tool to create a hauora needs assessment for patients in whānau, looking at all the things that could possibly contribute to fast turnaround times coming back into hospital within days, but also trying to take care of just the simple needs and basic needs that whānau were crying out for to be able to keep their whānau unit well once they left hospital. And then it's morphed into what we call now the FIDI service. So to kickstart our kōrero this morning, I think we'll ground it in kōrero from our team here, and just to depict some of the realities of patients that you won't be surprising for any of you. We've all have whānau coming through the hospital service and had good experiences and not so good experiences. So this experience is of Rangi, and we'll start there and then go into our presentation.
So Rangi had multiple referrals to FIDI in September and December of 2023 from ophthalmology, high risk foot clinic, and Rangi was non-engaging, missing multiple appointments with ophthalmology, high risk foot clinic, vascular, diabetology, imaging and district nurses. He would attend some appointments and then miss the next one.
Rangi had a medical history of type 2 diabetes, right hallux amputation, and a complete forefoot amputation. Throughout Rangi's journey with FIDI, he was later diagnosed with an acute kidney injury, hypertension, and had further toe amputations and a left below the knee amputation.
Rangi shared with us his previous traumatic experiences in life and at the hospital. He's currently unable to afford to make it to his hospital appointments or GP. Rhiannon and I had an added bonus of working with Rangi at previous positions, and were able to build trust through whakawhanaungatanga. Rangi was able to trust both of us and began to take charge of his hauora. Due to Rangi living rurally, FIDI helped him to establish transport routes and assisted with backdating his National Travel Assistance and accompanying him to his appointments.
Rangi would get overwhelmed and frustrated with multiple people contacting him with no clear plan. Rangi has built trust with the FIDI team, and FIDI would help him liaise with other staff and clinics to coordinate appointments for Rangi.
So FIDI aided with accommodation and booked for pre-surgery and supported with KaiPaks. We completed a whānau hauora assessment and identified his needs. We helped him connect with his local community services, and when we first met Rangi, his goal was, honestly, to be the biggest drug dealer in Aotearoa, which he tells us he achieved. Rangi was that in the past, but now he has aspirations of helping his whānau and community. He has been interacting with others in his hapori too now.
We have provided education for smoking cessation, supported with nicotine replacement therapy. We have educated Rangi on his diet influencing his blood glucose level. We supported with GP registration, prescription management, and GP follow-up care. We aided with health screening and immunisations. Referrals were completed for acute home-based supports and inpatient kaitiaki consultations to ensure Rangi was safely discharged after multiple hospital admissions. Since FIDI involvement, Rangi has not missed an appointment since 14th of December 2023. He has attended over 20 appointments in a row, the longest consecutive appointments attended. Rangi is now engaging with not only the FIDI team, but also the hospital system. Staff who knew Rangi previously have noticed a change in his demeanour, with communication to be more autonomous. He proactively engages FIDI staff and feels empowered in taking charge of his healthcare. Rangi is confident to book appointments himself, organises transport, and no longer needs an advocate at all of his appointments.
Okay. Choice. Okay, so we can roll, and I just want to acknowledge all the other Whiri team members that are here today, but also our other community from Te Whatuora Waikato that are here that also link into and Te o kia ora, everyone. Anyway, everyone, acknowledging everyone, not forgetting anyone. But it's not just the Whiri team alone. It's all like anything. It's based on relationships, and that's how we make things work for our whānau in the hospital. Oh, do I have it? Okay, so this is just one story. The realities of our whānau coming through the hospital are very broad and varied, but the key unifier and commonality between all of our whānau is the context within which they're presenting to the hospital. And the context being, no surprise, but our historical background of colonisation, loss of land, loss of economic base. You link that up with the design of the health service, which has not been Māori up until recently. Māori have not contributed to the design of the health service in any of the iterations. So who it was designed by and who it is being designed for has had significant impact on how our whānau journey through the hospital system. So that gave rise to the opportunity for Whiri to be redesigned from Hāti Hauora in paediatric setting into the adult setting in the hospital. And so what we do always is we're really mindful that we have to be held accountable. Our team, the whole model of care has to be held accountable to our whānau and community. So at the centre of it, and we've heard it already today, at the centre of our model of care is whānau voice, and it's about intentionally shifting the power away from the establishment, away from the hospital structures, and even away from ourselves as clinicians and back into the hands of our whānau. And we have to intentionally do this because it's easy to slip into the role of I'm working in the hospital, so I may know a bit more, but no, I always get reminded, no, you don't. So we have our po. So this is just, these are the po that help ground us in our mahi. I don't know if everyone can read that, but Te Tiriti based, always looking at how we whakamana whānau and hapori, and and we do have a hapori team as well. How we transform the system, how our care is holistic and whānau and inclusive, and we achieve that by really continuously tapping into our whānau and saying, how are we doing? This is the latest iteration of what we're doing. Is it fit for purpose? And we get our feedback through co-design in that way. And it's been really helpful for all of the teams to come together and work as a unified ecosystem to try and ensure that we are answering to the needs of our whānau. So this is a bit about the Whiri model of care. Basically, we're trying to be holistic here. So we have as we heard in Rangi's case, we have a whānau hauora assessment, which is usually carried out by our kaiwhiri or navigators, hauora navigators. The assessment is very broad and it's not rocket science, but it really is tapping into the needs that our community keep feeding back to us that are currently existing in the community. A key point to that whānau hauora assessment is that there's always a link to a resource. So you can't find an issue without having a solution or at least a link for whānau to be able to gain support. Wow. Ko tangi te pere already? So we're halfway through. Okay. Oh, that's my 1 minute. Okay, cool. So what else can I do? Key is action focused. So we identify these needs and then it always has to translate into action. We're sick of frameworks and we're sick of strategies that, hold us to account, but there's no action to follow. So key to what we do is measuring. We measure what we're doing. We're measuring outcomes and outputs and always trying to improve. We have evaluation processes in what we do. The model of care, I haven't really explained all of it, but we have a whānau hauora assessment with our kaiwhiri, and then alongside that stands our clinical clinical team within the hospital. So it's been really crucial to have that clinical care coordination to help navigate our whānau alongside the kaiwhiri. Some of it, as you've heard, is like streamlining appointments, streamlining services. Some of it is advocacy. So we're able to advocate into the services with the clinical team that and the services that our whānau are engaging with. There is a GP on board with our team, and there's clinical hub, or we have regular meetings where we'll discuss patients, and there's an integration, a whole view of what's happening for that patient or whānau, and then we take action. If we liken it to a metaphor, when whānau come through the doors, and this is what's come through our co-design process, is that the service has to look and feel Māori. So whānau have to feel reflected in this model of care. And so we sometimes perceive it as like a pōwhiri process. So when you're coming through the doors of the hospital, you may not feel tau at that time, and depending on why you've been referred, you may not feel tau. So our team will journey with you, alongside you, and every whānau and patient is different, but we'll journey with you until you feel settled in that service or in the hospital setting, and that power has definitely shifted into your hands. And each patient and whānau their needs are going to be different, but that is that's often the view of the team, and the team who are amazing, clinical nurse specialist led, the team know when that time has taken place. And so in a nutshell, I think that is the most. So within, I just want to say that that our team have been working across cardiology. We're currently working in ophthalmology. In the past, we've worked across ENT. We're looking to go into dental services. We get referrals through from the hospital, so ad hoc referrals from lots of different services that have heard about us. The key challenge that we have is sustainable funding as well as capacity, because as you know, once we got out, we were inundated with requests, and it's really hard to unsee things that you know need support. And so we are looking to secure some sustainable funding in the near future, but it's a beautiful model of care. There's been a lot of interest across the nation to adopt something similar. And I'd just like to reiterate, there's some other beautiful models of care out there too. We're not the only one. And it would be really nice if we could all cohesively come together and share resources, share learning for our whānau in the future. So kia ora. Sorry, it's a bit rushed. Yep. We can take questions later. Kia ora.
So we'll just give the gifts. So another fantastic example when you put the power in whānau's hands, but it had to start from people who had a vision and had a passion and had drive to not ask for permission. Yeah, we got the funding later, but not ask for permission, but that's actually what's required often to make a difference in a system that hasn't privileged everyone. So just another big paki for the team. So I want to now ask Dr. Kara Eckermann and Waimara Roa to come up. So we've had the example of whiri in the hospital, and now here's our kōrero around whiri in the community. And Waimara is my niece.
Morena tātou. Beautiful to be in this lovely space with you all today. Ko Kara Eckermann tuku ingoa, he uri ahau no Ngāti Maniapoto. I'm a GP by background and have been clinical lead of Whiri Hapori while it was around, and am now working with Hauraki PHO, which we're going to talk about shortly with our mahi together.
Mauri ora kia tata katoa, ko ai marama mai aroa tōku ingoa, ko Waima e tahi atu ingoa mōku. E mahi anau I te business analyst, I roto I te waka o te Punahora matua o Hauraki PHO. Kia ora.
So how can we deliver good quality primary and community healthcare? Healthcare that's equitable, reaching Māori, Pacific, tangata whaikaha and our rural whānau, that focuses on whānau needs, not just an individual's illness or the services needs. That focuses on health promotion and disease prevention, equally as well as it does the treatment of illness, and delivers that care as close as possible to where a person lives and works. These are all requirements that are in the World Health Organization's definition of what good primary healthcare is. And today we'd like to show you a Mātauranga Māori community model that was rolled out during the COVID pandemic that I think fulfilled some of these requirements. Hauraki PHO has taken on that model, and we're going to talk to you today about how we're rolling that out with the new comprehensive primary care and community teams. So Whiri Hapori. Whiri Hapori was a community whānau holder integrated response initiative, and we worked alongside Whiri Hohipera and the Whiri research team with Myra. Okay. It's a Mātauranga Māori model that's integrated, working across the community, primary and secondary care, and it's delivered mainly by an unregulated workforce. So our Māori kaiawhina, and with Whiri Hapori, these were mainly Māori kaiawhina out in the communities working with their local whānau. They're supported by clinically by nurses from the beginning of the whānau journey. So nurses do triage, they do nurse first engagement calls, they're available for clinical escalation should the kaiawhina require it. They were vaccinators, so they were going into people's homes and vaccinating, and they were a direct link to primary and secondary care. They had a GP available for support. If a whānau had poor access to a GP, so this was particularly important for our rural whānau with difficult access and for our unenrolled whānau. And we had a clinical lead, who was me, organising clinical escalation pathways, providing a link to our governance teams, and performing continuous quality improvement. So the whānau holder assessment is the tool that's used by the kaiawhina to help deliver care, and it's on a digital platform, and the aims of it are to identify whānau need, to provide wellbeing and health information to the whānau, and to improve connection to wellbeing services. It's adaptable to different kaupapa and places. It has clinical escalation pathways built in it. And being digital, it allows you to measure outcomes, which is important for evaluation, reporting, and looking for funding. So here is an example of just some of the services that are in the whānau holder assessment, but it's by no means all, it's really comprehensive. So Whiri Hapori was born out of the COVID Directorate in April 2023. It was a Te Whatu Ora initiative, and we worked with 12 care coordination hubs around the Waikato Rohe, 9 of which were iwi mandated, 1 Pacific and 1 ethnic based out of the Refugee Centre in Hamilton. We provided care for whānau isolating with COVID, but we incorporated the Whiri model of care into it as we really identified the need for more comprehensive healthcare. We worked with 3 whānau holder assessments, so we built 3 during our time, and all of these sourced referrals differently. So we had one, our post-COVID bar, which was based on prioritised COVID data lists, which targeted those who are most at risk of winter illness. We created Te Whanui after a wānanga with the hubs because they wanted to be able to refer whānau that they saw a need in, and it allowed for self-referrals too. And we had the Tamariki whā, which was built in collaboration with the paediatric team at the hospital and allows for the referral of any Māori or Pacifica child who's been admitted to Waikato Hospital. So in the 14 months that Whiri Hapori existed, we were able to deliver over 1,500 whānau hauora assessments to whānau. Our nurses were able to directly deliver more than 1,200 immunisations, and they were also able to help other hauora Māori providers around the Waikato Rohe, and together they were able to deliver over 7,000 immunisations. We were able to address unmet need. So especially those whānau priorities like kai, healthy home support, financial support, as well as supporting to different things like screening. So over 140 people were supported to screening, over 150 tamariki to oral health enrolment. And whānau really liked this approach. Our whānau feedback surveys tell us, give us really overwhelmingly positive feedback. There's many stories of increased trust and engagement. And when asked how helpful they found this process for them, we got an average score of about 9 out of 10. It's really good for workforce development as well. So we've had many kaiawhina move on into workforce roles, health workforce roles like nursing, public health positions, mental health positions, and data analysts. Unfortunately, we weren't able to get continued funding, and we were disestablished in June 2024. However, Hauraki PHO has picked up our tamariki kaupapa, and Waimarama is going to tell you how that's being rolled out with the comprehensive primary care teams.
Cool. So CPCT, or the Comprehensive Primary and Community Teams, is a population health approach. So it's not just for the enrolled population, which people typically associate PHOs with. Lady Moxon talked about the inequities experienced by Māori compel an urgent and thorough intervention in Anei Tētahi Ara. So the FAR is a kaupapa Māori approach to a comprehensive needs assessment and is as thorough as the funded services within that region. So part of our role as the change managers is to understand the services that whānau should have access to, enable the systems to make sure our kaimahi are able to offer that to whānau. And then whānau then have the choice on whether they'd like to take that service on or not and be connected. And as I heard, we had some cancer care coordinators in the room today. We see the care coordinators as a connection, a bridge into those services as well. We have strict clinical escalation protocols built into our standard operating procedures, and we have GP as part of our kaupapa. Unlike a lot of other regions, we were able to secure a lot of Dr. Kara's time. Eventually, we hope that analysing some of the data will provide an evidence base to resource additional services within the region, because we'll be able to understand from the whānau narrative what might be missing for them. These are some of the CPCT attributes by contract. Our teams work hard to align to them, but the biggest part is making sure that we have access to clinicians to work at top of scope. So part of the whiri model is working alongside a kaiawhina so that whānau have that social service support and culturally appropriate support. And then the clinicians can work to meet that higher need, which aligns to the first one of working with whānau at the greatest with risk of inequitable health. Some of the clinicians that we tap into as well, some of the FTE that's been allocated to CPCT are pharmacists, physiotherapists, and extended care paramedics. So within the, this is our old slideshow. We realised we had a bit reduced time, so we've cut our slides down. At the bottom of this slide is our prioritisation matrix. So for Te Puna Hauora Matua o Hauraki, a big priority for us is our whānau that are living rurally, our tamariki coming especially out of our hospitals, wahine and tangata whaikaha. So within phase 1, we're looking at the whānau that are being disconnected because of a whole lot of our environmental factors. So when the state highways were shut down. A lot of our extended care paramedics moved into the North Coromandel region and to Pairua to meet some of the whānau who have been disconnected on our roads. Within phase 2, we've been looking at our tamariki being discharged from Waikato Hospital and trying to meet their needs as they are released. That's a focus on Pari Waikato. Within Pari Hauraki, we're looking in phase 3 at connecting priority wahine to screening through an opportunistic hospital and community touchpoints initiative. And then within phase 4, we see some synergies between the CPCT model, the way that our long-term conditions teams are currently operating, and the way that our extended care teams operate. So we see the ability to merge all of those models together and meet whānau where they're at that time. A big enabler as part of these kaupapa has been data. So the data that enables our kaimahi to connect in with whānau, whether that's the referral system that they come in through, or whether that's the data matching that goes on in the back end of the systems to make sure that we're meeting the right people at the right times. We also see our systems and integrated systems as a key enabler, so making sure that the hospital systems can connect into the primary care systems as well as the community systems. That's been a big issue for some of the CPCT rollouts across the motu. The service buy-in, so the rest of the funded services in the region having the ability to take on whānau once that need has been identified, and making sure our teams are connected in with all of those services. So during our training days, we have service days where we can all come together, whakawhanaunga, and make sure we make those connections to get whānau the best access possible. And also the staff enablement to support the recruitment challenges that everyone's experiencing across the motu within healthcare. So phase 1 is quite far into implementation phase, as you can see, and we've got continuous quality improvement going across all of our phases. And our initiative runs right across Pari Hauraki and Pari Waikato. We're a bit further ahead than some of the other CPCT rollouts across the motu. And we see that as a huge advantage because we can use our learnings and insights from phases 1 through 3 to help everyone's rollout. So we'll be presenting to Te Tai Rāwhiti this week as well to share some of our learnings and help support their region rollout too. This is just a quick example of how our tamariki process works. So from referral through triaging, the cases are created. Our systems that we've used to enable our process is Clinical Workstation for continuity of care for our clinicians, Monday.com for our case management, and we've advanced our privacy and security settings up a bit. And also Qualtrics that our comprehensive health needs assessment sits on. So all of our systems can talk to each other. We've got a data and enablement person sitting behind the scenes to make sure that everything flows through nicely, and Kara and I as the change managers to support the process. I think that was our bell to finish up. Ngā mihi.
Before you go, I just want to give you, before you go, sit down at the table. Well, haven't we been blessed with some beautiful, oh, I've got a hand up. Oh yeah, 290, yeah. So now we're going to, so just a big acknowledgement for our panel that have spoken so far. So big applause. You grab a seat over here and I'm going to move. Yeah. So now I'd just like to invite Elizabeth Gray and Arapita Haddon to the stage, and they're going to facilitate a wānanga session on integrated care with our panel. Kia ora, homai te pakapaki.
Tēnā tātou te whare a e mihi ana kia koutou I tuwhera I te rangi nei, tātou. I tuwhera I te rangi nei koutou o te kōhao I whakawātea mai a koutou anō I tēnei whakaruru hau o mātou o tātou, tēnā tātou. My name is Elizabeth Gray. I come from lots of places and I wear many hats. And today this hat is facilitating our wānanga session today. I'll let Hine Moa introduce herself and we'll carry on.
Mōrena, mauri ora ki a tātou, ngā mihi o tēnei ata. Ko wai tēnei tuaki ana no Te Arawa Waka, no Ngāti Kia, Ngāti Tuara, no Ngāti Pikiao, no Ngāti Rongomai, ka hoki mai ki roto o Ngāti Raukawa hoki. Ko Hini Moa hau, Hini Moa Jones. Mōrena. And Libby and I are going to be facilitating a panel session with these incredible mārei kura, te reo wahine, te reo no māringi ana I te kauai o Muriranga Whenua. E rā kōrero katoa no reira. Yeah, that's us.
Ka pai. Before we get into the swing of things, I'm just going to introduce you to Arapira Haddon down below there, who will be setting a loop of kūkau, taonga puoro. Can everyone say kūkau? Kūkau. Ka pai. Often at times we're living too far in the future, it's anxiety, and we're living too far in the past, and that's stress. And so the ability to hear the reo or the oro of our kūkau helps us bring us back to the present, to bring us back to the noa, o kia taua noa I tātou, I raro I tēnei whare o tātou. So we'll pop that on the loop now once we get that mic set up. We've got a few questions for us all, and then we can pose questions. So if you can think about some questions you might have wanted to ask but couldn't get to ask in that time before, then no mai.
Well, I was hoping to be roaming, so aroha mai. I'll be turning around, we'll be turning around a little bit. I te tuatahi, me mihi ka tika kia koutou katoa, kua kawe mai I ngā reo o te hāpore, I te reo o kere, I te reo o rangi. Oh, cool. I ngā reo o ngā whānau, I te mea I te mutunga o te rangi, koera te taki kei konei tātou katoa, mo te hauoratanga, mo te orangatanga o te whānau te taki. Nō reira, ngā mihi mutunga kore e rere atu ana ki a koutou. Me o koutou whakapau kaha mō te whānau te taki. Hi. Okay, well, what I'm thinking of is in terms of a place to start is this morning, Mark laid down this really beautiful little kōrero. So everybody, what did we do this morning? And this is our mauri, ne? So I'm just going to start, and I think I'm going to go to you, Maira, if you're all right with that. So we've got our mauri running. Here we are. In all of the systems that we have to operate in that you've all spoken about this morning. And we're trying to infiltrate, penetrate, consume, recreate, reimagine all of these systems using our mātauranga Māori, Māori lens, and everything that we've got. So Maira, if this is your Māori oscillating around, and this is the Māori of whiri and everything that whiri has become, and you take your Māori and what do? If you're going to throw the Māori of whiri at any of the systems that you operate in, can you tell me what that would look like? What is that Māori? One little part of the Māori of whiri that you would throw at the system to benefit what you're up to with whiri. Is that too cryptic? Maybe I should have got Libby to start.
Kia ora, he pātai pai tērā. I think at this stage, the Māori that I would share out into the wider net is is the empowerment of whānau. That the component of whiri is that we, even though there's shifting tides within the environment that we're all working in and living in out in the community, we still hold a lot of power. And we heard from Lady Moxham this morning that we've just got to get on and do it. So whiri is all about that, doing what you can do with what you have and never giving up. And so that's what I would share out and throw out into the cosmos, which lands hopefully with a funder. But that empowerment, that we still have a lot that we can do, even though it looks quite dire in some spaces that we're working in, we still have a lot of skills. And the most important part to all of that is kotahitanga. Kotahitanga. Yeah, kia ora.
What I'd like to see tuku for people in our care is their empowerment. People come into our care and they have no choices, they have no power, and that comes to their healthcare as well and their well-being. And where I'd really like to see it start is by giving them some say in some part of their journey with us. Because at the moment they have.
I think that the most important thing for all of us right now in terms of the health system is our own, and we have to say anything, implementation of our own tiritanga, our own Māori manifesto, and know that with whānau in the centre of everything we do and everything we serve in the way in which we should serve, if they are in the centre, then their health system will be a very different place. That's not how it's been, and it's not how it is today. So we have to change it. If there's one thing we can all do, is to change that. And then those wraparound integrated services will be meaningful. They will come into play. But they can't do that if everybody is on their own waka, rowing in their own directions.
Kia ora, ngā mihi. I'm just going to invite you all, if there's any moment you want to pierce into the space, if you have a kōrero to share, a pātai, please, kia kaha, raise your hand and we'll run over with a microphone. I think that's how we're going to go. Anyone at this stage want to kōrero? Kyle?
Hilda, I have a question, and thank you so much for the presentations that have been shared with us this morning. I had two questions, but I'll direct the first question to our tohine from the palliative care within the justice system. I was really interested in the compassionate release process, and interested in if there's any representation from either your teams or for Māori on that panel when we're talking about compassionate release within the parole board jurisdiction. Like, so when they're making those decisions, who's representing that patient or whānau on that, in that decision-making process.
Hello, there you are. I think in fairness, when we spoke about that, the decisions are left with the parole board, and the parole board are made up of not people that we choose, but rather the high level in terms of justice, doctors. There are clinicians. I don't actually know if there are Māori representation, but I was kind of gearing towards Tania over here saying, hey, that's where you need to be. Even though, you know, Lady Moxon, those are the roles that we need to be sitting in order to have that input into what it might look like from a Te Ao Māori point of view. Yeah, but I don't know who actually sits on the parole board. I think what's important to know is that there are opportunity. What we do have at National Office, which is the team I'm in, and that's the Toi Ora team. We are responsible for rolling out the Māori Health Plan across the country. But as you know, and I have to be very careful what I say here, as you know, there are some great changes that have come about as a result of